Good afternoon. I'm so happy everyone can join us today for our call on clinical session. We're speaking with Kim Atrabin, who is the Infection Prevention Director at Tampa General Hospital. They actually just presented a really great poster at National APIC 2025 called Novel Decolonization Protocol for Hemodialysis Patients to Reduce Bloodstream Infections. So Kim, first and foremost, I want to ask you, I know that you all had a decolonization protocol already in place to include CHG bathing alongside Profend for nasal decolonization. What did this new protocol layer in terms of additional patient population specifically?
That's great. So we already have a universal decolonization protocol for our ICUs and our step downs. That's already daily CHG, twice daily Profend nasal antiseptic. Outside of the ICUs, if the patient had a central line, they were already receiving a CHG bag. So the new protocol now focused specifically on hemodialysis patients, regardless of whether there was a central line or not. We wanted to make sure we focused on this patient population. So the build was already there, which was very, very nice, right? So in terms of our EMR, some of that functionality, supplies, everything was already there. We just had to operationalize this patient population. So essentially, outside of the ICUs, everybody that's a hemodialysis patient, we want them to get a daily CHG bath, and we want Profend twice a day as long as they are receiving hemodialysis.
Perfect. Okay, and I think that's really great, and we'll tie into this in a few questions. But the fact that you're focusing on patients that both have central lines and reducing bacteremias in those that do not have central lines, which of course is going to be really pertinent as we start to discuss best practice interventions for healthcare onset bacteremia and the prevention of that sort of event.
Yeah, that's a great call because this started originally from CLABSI, right? We have a CLABSI work group that meets monthly. We're exploring trends. Where is there opportunity to improve infections? And so it started as a CLABSI initiative to reduce hemodialysis CLABSIs. But as we started drilling into this, it makes more sense from a big picture patient safety perspective. We don't really just want to improve CLABSIs, right? Like in hemodialysis patients, we just don't want them to get MRSA infections or any bloodstream infection, right? So there's always opportunity in this patient population to go above and beyond what's expected of us from a regulatory perspective. So that's definitely where we just went of let's address the entire patient population for hemodialysis, right? And hopefully we will start getting benefits that are beyond just CLABSIs, right? That we saw some benefits in bloodstream infections and whatnot.
Perfect. So first and foremost, I think this is such a great piece of research. So what evidence or data inspired the initiation of a nasal decolonization protocol specifically for the non-ICU hemodialysis patient population?
Yeah, it's a great question. So unfortunately, we were struggling with CLABSIs, right? So that's certainly one of those elements. The IPs in the audience will understand that concept. We were struggling with CLABSIs. When we really started to trend it out, we were seeing more CLABSIs, specifically in our hemodialysis patients and with skin organisms. So it really started getting the whole team to start thinking outside the box. What do we need to do? Of course, when you see that increase in a trend with skin organisms, my first go round was around scrub the hub, vascular access care, aseptic technique. We were seeing some improvement with that, but certainly not enough. So it really started us to think, what do we do in other settings? And this is where that review of guidelines and review of literature got us going down this pathway of, if we do universal decolonization in the ICU, and for us, we do that, we extend it to our step downs. Why can't we do it in this population, right? Does that exist? What does that look like? Could we start exploring? And fortunately for us, we've got a leadership team that's really game for allowing us to try new things, to be innovative. And if we fail, then just fail fast, right? So I was really lucky to have the leadership that we have that was willing to take the chance on this. Of course, we showed them the data that said, here's why we should really be investing in this protocol.
That's fantastic. I love how engaged your team is and you are regarding patient safety and taking the steps with a more progressive approach. So Tell me about the statistically significant reduction that you all saw in the positive blood culture rates outside of the ICUs and step downs to include your non-hemodialysis patients. Do you think this was at all associated with Profend use, since this particular study population may not have included patients who received Profend?
Yeah, that's a great question because for us, so we were actually looking at trying to figure out how can we track this, right? And we really didn't have a good way for us in the database, an easy way to pull out how to see whether or not this improved bloodstream infections or not in that patient population. So really by extension, we started looking at just overall blood culture results. And so and so I think that's fantastic, right? So that was the first thing is when I start seeing a reduction, I'm excited, right? Regardless of what that intervention is that caused that reduction, at the end of the day, if more of my patients are going home without an infection, that's a win in my books, right? Then we've got to maybe go back and figure out what did we do. And that is sometimes the challenge for us. So I'll say, I assume we're like many other facilities, we do not live in a research environment, right? We are very much so numerous interventions happening at once, lots of engaged partners. We're a very large facility. We're over 1,000 beds. So sometimes there are initiatives that are even happening that I wouldn't have even thought, but may have a downstream effect of improving my infections or improving certain process measures. So although we didn't have anything specifically going for this patient population around blood cultures, there may always be something else that was not anticipated that may have been affecting this. So this is great for us. We're really happy about it. I think it warrants additional review. I would love to see other facilities try this and see if they gain some of those same benefits, especially as we start entering the age of possible onset bacteremia.
Absolutely. So your results data show a 34% reduction in hemodialysis CLABSI rates, but it was not statistically significant, right? So how do you interpret this result in terms of clinical relevance and impacts to good patient outcomes, especially perhaps in the context of the HOB surveillance case definition, which is healthcare onset bacteremia fungemia?
Yeah, that's a great call. So for us, this is really fantastic. Obviously, we were really excited. Improved patient safety is a win, regardless of what's causing it. We did have a lot of interventions that were happening at the same time, specifically around CLABSI. So the hard part for us is to really tease out whether it was directly related to Profend or something else. I do think that that could have been a contributing factor for sure, but it definitely needs to be replicated, right? Think of this as proof of concept. We need somebody else to go down that road. I think where there's some expansion of the product and even some expansion of infection prevention, right, is to really move away from this concept of only focusing on CLABSI, only focusing on what we report nationally. And so we've done some work as well in other realms and other patient populations. And in this case, this would be, I'm really focusing on hemodialysis patients, regardless of whether you had a central line or not, because at the end of the day, not even for reporting purposes, but at the end of the day, it's the right thing to do, right? Like the focus should be around patient safety. Regulatory and reporting structures should almost be second. And I think that's a big thing too. And this is, I'm kind of getting off topic here, but I think that's a big thing on, does your leadership support that concept? And do they support those initiatives and that innovation too? So I think this was one of those elements that we could really bring back to really great leadership support.
Awesome. All right, so from an operations standpoint and facilitating this intervention, what were some of the most significant challenges in integrating CHG and povidone iodine documentation into the medication administration report, or the MAR, and how were they addressed? That's question one. This is kind of a two-part. And then how did you ensure alignment and cooperation from nephrology providers, especially considering that this was like a decentralized approach to hemodialysis care?
Okay, so great question. So first, I'd say this was not a new product to our hospital, right? So we've already done CHG bathing. We already had Profend nasal antiseptic. So both of those products are already on our MAR. So that was a win for us, right? We didn't have to necessarily get it on there. What we did have to do is both of those products for us, the way that we have our universal decolonization protocol, it's as a NIP. So I don't need a provider order. The nurses know to just run with that protocol, which is great. This protocol, we did a little bit differently. We wanted nephrology to be actively engaged. And because it was going to be dependent upon when the patient was actually receiving hemodialysis, we incorporated these orders into our nephrology order set. So if we're going to go down that road, I need really good nephrology buy-in, right? So this was not something that the infection prevention team just willy-nilly threw out there, right? This was absolutely in collaboration with nephrology. We would be at their meetings routinely. They have monthly QAPI meetings that we talk about. We review some cases with them as well. And then we are reviewing trends with them. What do you think about this concept? What about this protocol? Are you open to this, right? So they got, their medical director was completely on board, completely bought in. And so when we started talking about this, that was one of their caveats. Make it as an order, put it into the nephrology order set. So that very first time we order hemodialysis, that's that same time that we're going to roll out with these two these two products. It's auto defaulted, so it's really simple for the providers to go by. But there was still a lot of follow-up meetings, right? So we had a lot of opportunity to make sure that that they have that chance to remind them, are you using the order set? Are you using these products? We would do some follow-up. This is kind of that long-term sustainment. I'm going down that rabbit hole a little bit, but really important for that long-term sustainment. Once we went live, we're spot checking. Let's pick some random 20 hemodialysis patients. Have they received the protocol? Okay, maybe it's starting off slow. Maybe we only had 50, 60% compliance at first. We were missing some of those patients, right? So the more we could get in front of them and watch that compliance increase and that usage of the products increase. And really, once it was ordered for us, the nursing and the operational teams were going to perform it, right? We weren't worried about that. We just needed to make sure that the orders were placed. And so it took a couple of months. It's not like we had overnight success on the day of the go live. But we made sure that we built in some sustainment and some kind of process measures over time to make sure that the team were fed back the data so that they could see whether or not this is important and how it's important. Are they implementing what we're wanting?
That's fantastic. I really think that creates a formula for success, right?
Yeah,
So
yeah.
you've got the buy-in of the physician group, and then you also have a way to track the compliance for essentially the end user, the bedside staff. So that's fantastic.
Yeah, and I'd just say, I think one thing about that too is we didn't have a great mechanism to pull this out. I can certainly get a report from IT, but if anybody else has trouble, sometimes it takes a little bit for me to get a report back from IT. So I didn't want to necessarily wait for that. So if that's the case, this is where we can do small spot checks, and that's where I'm really a big proponent of data sampling. I really like that concept. That's something that we can say, I'm going to take 30 minutes out of my day, and we're just going to do some chart reviews, right? It doesn't have to do this extensive deep dive, but it'll give me a gauge of whether or not we're using the protocol, right?
Fantastic.
And that was helpful.
How did frontline staff respond when the results became available from this intervention? Did seeing these outcomes influence adherence or buy-in moving forward within your facility?
Yeah, that's a good one. That's a great one, Holly. What I'd say is actually it was the hemodialysis staff. So the frontline hemodialysis staff, they were the ones that really started getting the buy-in, right? Because we were reporting to them infections, right? And they certainly get not competitive, but certainly don't want their patients to get an infection, right? So they were thinking about things. They were joining us in these meetings and collaborative discussions around how can we keep our patients safe. So when they started to see their infections decline and decrease, they're excited, right? So at the end of the day, anything that gets them excited about this, excited about infection prevention practices, infection prevention protocols, and something around patient safety, that's a win, right? And it actually extends more than just the one protocol that you're working on, right? So that's always something to remember. So at the same time, we've really done a lot of making sure we increase our presence down there too, right? So they're working on making sure that they don't see this order. So here's the other thing, right? So you've got the nephrology that's ordering. We do our sample checks, but now they know as well, in our dialysis team, they will look up how come this patient hasn't received Profend or hasn't received their CHT bath in the last, 12 hours or so. So they are now starting to do some of that sustainment work instead of us, which is really great.
That's great. Anytime you can empower the frontline staff to really be champions because of the good outcomes. That's fantastic.
And I think you're spot on that too, right? Once they own it and become really that gauge and that needle of, are we going to drive that success? That's so much better and it has so much more impact than if I were to push it, right?
Yeah. So absolutely. Were there any secondary benefits like reduced antibiotic use or reduced hospital stays due to infections prevented that surfaced as a result of fewer bloodstream infections? Were you able to kind of quantify
Great.
or qualify any of that
Yeah,
data?
that's so hard. I love the question. I just don't know that I have a great answer for you. So it's really difficult to quantify that. And I say it only because we have so much going on. Like I know our antimicrobial stewardship team is actually really starting to get some oomph behind reduced antibiotic usage and appropriate antibiotic usage. So I am seeing reductions in our antibiotic overuse. The challenge is how can I align it with this protocol or not? Likewise, the same concept for reduced hospital stays, readmissions, so length of stay. We have a huge work group that's going on because we're really struggling with capacity right now. We are just over capacity like many other facilities across the country. So there's so much going on with that. So same concept. I do think we're seeing some of the benefits of it. I just don't know how to quantify that. But this is where like if you have other facilities that have maybe less interventions going on, less projects happening at the same time, you could probably kind of duplicate this. And that's what I would love to see some other facilities kind of go down that road and see what they find for results.
Yeah, and I think that's so important for,
Yeah.
contributing to the body of evidence on this topic. So Kim, I want to thank you so much for your time today. This was really a great delve into the work that your team is putting forth, that you and the team are doing there at Tampa General, and it's really showing off in terms of good patient outcomes. So I want to applaud your efforts.
Thanks, Holly. It's been a great project. We're keeping it going, and hopefully we can do some more publication and research in the future.